Good evening and welcome to the short presentation on particulate bone augmentation using a Megagen iGen titanium membrane. As most of you know from our previous lectures, I'm very much a strong advocate of autogenous bone and autogenous bone blocks for various reasons. One of the things that's very, very important in establishing ideal soft tissue is bone. And in order to create the ideal soft tissue that we are looking for in all our implantology, one of the most critical things is bone, as has been explained by Uli Grunder in the International Journal of Periorestorative, where he said that stable bone surrounding a well-integrated implant is critical for long-term aesthetic stability. We also know from other studies such as Spray et al. As well as Grunder et al. That we require more than 2 millimeters of buccal bone in order for that soft tissue to stay stable over the long term. And if we don't have that 2 millimeters of buccal bone, we actually aren't going to keep that soft tissue nice and thick, as I showed you in the first few slides of our presentation. There are a couple of factors which are very important in creating good bone. These factors are graft stability, space maintenance, blood supply, and implant stability. And those are the four factors which I use quite commonly and which are very important in developing good, successful bone augmentation techniques. When we're talking about graft stability, we're talking about the immobile graft. In other words, it is very, very important that we have no movement of the bone whatsoever. Because you can imagine if there's any movement of the bone, what happens is that it's very, very difficult for angiogenesis to take place. And as a result of that, we get a callus formation. And with callus formation, we actually get resorption and non-union of the bone. And as a result, we do not get the type of bone that we are looking for. A lot of times the membrane that we utilize to try and give us that graft stability dissolves a little bit too quickly, and as a result we either don't get a result or we get a very poor result. The other factor with these synthetic membranes that dissolve is they really don't create and don't give us the space maintenance that's required for good blood supply to flow into these areas. Now, if we look at the different types of techniques, and these are just courtesy of Craig Misch, and if we look at the titanium mesh or the titanium reinforced membranes, these are kind of membranes which really give us phenomenal graft stability. They create space maintenance, which allows our blood supply to actually come into its own and to supply. And when we use these type of membranes, we really get phenomenal types of bone. One of the problems with these type of grafts, or rather a few of the problems with these grafts, is number one, when we're using synthetic bone alone and we're using these membranes, they do tend to take a long time for them to convert to the patient's own bone. And sometimes we need to wait anywhere between 6 and 9 months before we've really got good, healthy, strong bone. If we do go in earlier, we tend to end up with slight mushy bone, which is not really great consistency, and we actually hope afterwards that it's going to convert, and sometimes we don't really know whether it does or not. The other issue with these kind of situations is that we end up with a situation where you may get much higher risk of complications, such as exposure, such as graft infection, etc. And some studies purport to have complications of up to 50%, which is really, really high for this type of technique. And I think in a lot of cases, if you do say to your patient, there's a possibility of a 50% complication rate, you might find that they don't actually go for that kind of treatment. So there's pluses and minuses for each one of these things. The other type of technique, of course, is autogenous bone, which is one of my favorites. And here's one of my cases, which shows you the autogenous bone blocks that we use. And this obviously is phenomenal because, number one, it's the patient's own bone. It's osteogenic, it's osteoinductive, it's osteoconductive. The conversion rate of the autogenous particles within the bone is very, very quick. And generally within 3 months that is converted if you're using thin plating the way we do as described by Faud Curry in Germany. And really a phenomenal technique. But obviously this is negatives as well, because one of the negatives is that when you tell patients that you need to harvest bone from another area, really a lot of them are pretty much out the door before they've even started treatment. So we need to have something that's going to give us really a good result without the negative of having to harvest someone's bone, but still without the negative of not having the graft stability, the space maintenance, which allows good blood supply to come in. The fourth factor that I take into consideration is how much bone we have for implant stability, because this really determines whether I can place my implant at the same time or whether I need to do a bone graft first on its own before I can place the implant. And you can see from the radiograph on top, from the cone beam CT scan, really a very, very thin bone plate, which doesn't really allow us to get good stability, as opposed to the case below, which really does give us good stability, where we can actually place an implant and do the bone augmentation at the same time. These factors are very, very important altogether. So they're not factors that we can really leave apart and do without one another. And it's a whole understanding of how these four factors come together, which really allows us to make sure that we get very, very successful bone augmentation techniques. Now, what I'd like to do now is just share a short video with you, which is basically shows a case where a patient of mine had external root resorption, and we'll look at the cone beam CT in a second. And instead of having the treatment done, he decided to go for a second opinion. He went for a second opinion, and the dentist decided not a problem, he can just cut away the gum and he'll put a nice filling in there and try and fix everything up just with a short filling. And you can see from this pre-op photograph pretty much with the mess that was left as a result of this. And now, instead of it being a situation where we could have done an immediate case, we now have to do a delayed type of healing and come back 2 months later and actually put the implant in. So let's start this short video and let's have a look and see what's going on. Here you can see the cone beam CT scan, and you can see the external root resorption. Here you can see we've used the Benex extractor to atraumatically remove the tooth, and you can see the damage to the buccal plate. Filling it with PRF membranes, and we've taken a small piece of tissue from the palate. This is a Buccal technique where we've harvested from the palate and we've sutured everything into place just to gain a little bit of soft tissue. 2 months later, the scan shows extensive damage, and now we're going to carry on and we're going to do our bone augmentation. The first thing we've done in this case, as I do in a lot of my cases, I make sure that we've got to be able to get tension-free closure, and that generally involves removal of the frenum if it is in that area. I like to use the laser. The laser is very quick, very easy, and bloodless. And here you can see just making a midline crestal incision. You'll know if you're doing the online education with Dental XP, the externship. In our flap design lecture, we talk about the fact that how important the midline incision is for healing, and the studies that show that the healing is best when you do a midline incision. And here we're doing our releasing incisions, one tooth either side. The reason I'm doing one tooth either side in this case is that because we're not using autogenous bone, it is a foreign material that we're going to be placing. I want to make sure that my incisions are well away from where I'm working from. So we're making butt joint incisions so that we get good blood supply for our closure, and we are making our incisions and slowly starting to raise our flap with the boozer elevator, and making sure we've got everything nice and clean. The first thing that we do once we've raised our flap is actually do a periosteal release, and the reason we do this is that it tends to bleed quite a lot because of the cutting into muscle. And if we do it at the very, very beginning, it means that by the time we get to close the flap, it's bled out, the body's taken care of the bleeding, and we tend not to get too much hematoma formation. And as a result of that, we get much better healing, faster healing, less trauma, less swelling, and less discomfort for the patient. You can see from this, you can see the bleeding that occurs as a result of this, and we're making sure that we get very, very passive closure in this case. So we're just going over our incisions, making sure that we're deep into the sulcus, not so that we don't cut off the tissue. And just testing to see that we can get passive closure, and you can see very, very nice closure there without any problems. Now we also just measure and make sure. Usually we use a stent. In this case, we didn't have a stent for whatever reason, And what we're doing is we're drilling here, and you can see the suction that we're using is actually a bone trap. It's an escalap bone trap, and you can see we're suctioning all the bone off because we know we're going to be utilizing this bone as our first part of graft. We want to do a sandwich technique, which is described by Wang in 2007. Once we've done our initial x-ray to check and see that everything's correct and that our implant is in the correct position, we can carry on. We're planning for a screw-retained type restoration. The implant system that we're using here is the Megagen implant system, which is the system I use a fair amount of these days. Very good for primary stability and designed for these iGen membranes, although these iGen membranes do have connections for all other implant systems, which makes it a very versatile and useful system. So the final positioning of the implant, making sure we're going to get it around 3 to 4 millimeters from the incisal edge. An important part of our treatment is also using the ISQ, the Ostel, to get a good level. And here you can see a nice level of 64. Not as high as we want yet, but it'll improve. And here what we're doing is just harvesting a little bit of the anterior nasal spine, because that gives us really fresh bone that allows us to pack against the implant and really get a good sandwich technique as described by Wang. What you see me placing in there is not a cover screw, but this is actually called a flat abutment, which goes over the top into the implant, which allows me to keep my membrane away and allows me to place my implants subcrestal, which is the way these implants should be placed. You can see there the packing of the autogenous bone over that site. First was the bone taken from the nasal sinus, from the nasal spine, and the others from the bone trap that we used. And here we're mixing a little bit of xenograft with PRF platelets. We've cut up a PRF membrane and we've mixed it into each other. And now we're just packing out to really create the nice thick bit of bone that we want. And obviously now we start looking at the fact that we need something to stabilize this bone, because the bone itself is not going to give us our stability. What we're going to do now is we're just going to place, which I like very, very much. I want to get as much bioability in this case. So what we do over here is we're going to place the membranes over to help with the stimulation of bone growth in the area, and as a result of that, hopefully get a much faster and much better bone growth in this area. Here you can see just another placement. We've placed 3 membranes over. And once we've placed 3 membranes over, we're now going to take the titanium membrane. You can see the membrane in place. And this membrane, you can see with the nice shoulder, which gives us the 2 to 3 millimeters that we require. And here we're going to just screw the cover screw pretty much onto the flat abutment that's inside there. And now you can see how this is really going to give us our graft stability, our space maintenance, and everything that's needed to make sure that we don't have any problems with blood supply. And the fact that everything's going to stay there, allows us to get everything in position. Because of the anterior nasal spine, I'm just cutting that small piece away so that everything sits a lot better. And you can also bend this into position nicely. So you can see here just a little bit of bending it into position so that it sits nicely and holds everything in position the way it should. So really a very, very nice membrane. You can also, there's different types of membranes. There's a whole number of different types, which gives you different widths, different heights, and also allows you to do vertical as well as horizontal augmentation with this technique. Here we're doing vertical mattress sutures into the corners to close our flap first, which are pretty much the most important type of sutures that we have. Here everything closing together. And the second one going into position there, just closing up, getting nice passive closure and making sure that everything closes well. The nice thing about these vertical mattress in the corners is that it really pulls the edges together rather than single interrupted sutures, which tend to pull the flap a little bit unsquare and not really as good for those type of sutures. The middle area gets a horizontal mattress crossover suture, which pretty much closes the whole that whole area. And what I like to do as well is just do a little bit of a releasing suture, just to tension releasing, which just is a horizontal mattress everting suture, and it just goes through and allows me to close up nicely. And there you can see just going through, closing up nicely, and just a little tension relieving there before we go and suture up the margins of the margins of this. Obviously, when one sutures the margins of these type of releasing incisions, it does tend to pull a little bit on the area, so they're not as passive as one would want. And just generally, I keep away from the top and just slowly suture everything together so that everything comes together very, very nicely. And here you can see the releasing incision sutured very, very nicely, and doing the same on the other side. Nice, simple interrupted sutures here. I'm going away from the top first, and I pull on there, and my last suture is the top one to get that last little bit nicely and positioned so that everything's placed well. I don't allow anything to grow into the area on its own. And here you can see very, very nicely closed up, everything in position. And here you can see a periapical of the membrane with the flat abutment and the cover screw, and you can see the membrane there. And here you can see beautifully how the membrane has kept the space, and you can see also a final scan just showing the membrane in position, and that'll be left for around 6 to 8 months so that everything can heal and we can get good bone in there. And once we do the exposure, it's actually very, very simple to remove, to take out the abutment, and to go straight from there to a provisional crown or a healing abutment, whichever you prefer. So with that, I say thank you very much for listening. Thank you for joining us on Dental XP, and we hope to see you back here, and we hope you join us for the externship, and we appreciate that you're here. Good night.